Hello everyone, happy evening, a very good evening. I hope and I believe all of you are doing well. A quick note everyone, am I audible and visible everyone? Am I audible and visible everyone? Just a minute. Okay, that's great guys. So here we are into our next UPSC CMS PYT sprint series with the next topic which is labor. Before this, we have done cardiology and neurology, right? Cardiology 1 is available on this YouTube channel. Cardiology 2 and neurology is available on Medsynapse app by Dr. Nikita. For the subscribers of the UPSC CMS course, the next topic after labor that we would be having, like you definitely get questions on that, is the topic of contraception that we are going to do today at 7:30 p.m. in app Medsynapse app by Dr. Nikita, again for UPSC CMS subscribers. Each of these topic discussion, is followed by a test, right? So the test on the topic of labor is already live, 35 questions test dedicated on this topic. So what I recommend is watch this video and then you give the test, so that you know that what kind of questions are asked, and you are doing the topics retrospectively. So we already have uploaded the test for cardiology and neurology along with those topics discussion. Third topic is labor. Then, like I said, the next we have is contraception, and after that we would do immunization and vaccines. So I'm hand picking the topics which are from which you get definite questions in UPSC CMS exam. Please beware, right? I'm not promising that I will make you do all the topics before the exam. This course on the Medsynapse app, we had launched it as a recorded course only with the previous sessions that are already available. But then, we are doing it. We are doing the live sessions as well. This is like an extra edge, extra benefit for the subscribers who are there. Though we had not promised, but we are doing it because I thought that I should be doing at least something for the UPSC CMS students, and hence this very very high yield series that we are doing. Okay. That's great, guys. I do remember your name, Rashmi Devani. I definitely remember you. Welcome back to the Medsynapse family. And, looking forward to crack your upcoming exams again together. I've also uploaded the PDF link, guys. I've uploaded the blank PDF. So if you want, you can make the notes as we discuss. And please do give the test after you watch the session, because that is what will help you in the active recall. And you will realize that even after reading or watching the video, where am I making mistakes? So what we will discuss in this topic is basically the normal labor, the science of it, and lightening, then true versus false labor pains, the physiology of labor initiation, the various stages of labor, some quick review of anatomy that questions have been asked in the UPSC CMS exam, monitoring progress, partograph versus the new labor care guide based on the WHO guidelines, and then the third stage, some quick questions on obstetric maneuvers and instrumentation, and some complications and abnormal labor like shoulder dystocia and cord prolapse. Quick points about that also we shall discuss. Okay, so let's start discussing this topic. The first one, normal labor, that is eutosia and preliminary signs. How do you define normal labor? So there has been a question on what is normal and what is not included in normal. So normal labor basically is spontaneous onset. Okay, it is spontaneous, not induced. Spontaneous onset at term, that is between 37 to 42 weeks. It should be vertex presentation. That means the head is the presenting part. It should result in a healthy mother and baby without any undue delay or complications. And vaginal delivery with episiotomy. Is it a normal labor? Yes, it is still a normal labor. But is the vaginal breech delivery considered as normal labor, even though it's breech, but it's a vaginal delivery? Is it normal labor? No. Because remember, all malpresentations, they are excluded from the normal labor. So remember, this is a question that has been asked. The vaginal breech delivery is not included in the definition, in the criteria of normal labor. Okay. Vertex presentation is what should be there, not breech. Going to lightening, which is the welcome sign. What is lightening basically? Lightening, imagine like it is lightening the abdomen, right? The pressure on the diaphragm of the mother because the baby is descending down into the pelvis. So when the fetal presenting part is descending into the pelvis, that is what is called as lightening. So because of that, what happens is the pressure on the diaphragm is relieved, and that is why the mother's respiration becomes easy now as compared to before. Now, when does it occur? Does it occur just before labor? In primigravida, it occurs 2 to 4 weeks before the labor. In multigravida, it is just before or during the early labor. So, primi mein pehle hota hai 2 to 4 weeks before. Now, associated symptoms. Now, because the baby is going down, the pressure on the diaphragm is relieved, but the pressure on the pelvic organs is increasing. So, that is why, the bladder compression is happening. Bladder pe pressure aa raha hai. So, it will be accompanied by increase in urinary frequency. So, remember, these bladder complaints are present there. Then you have, remember in the question, what was incorrect was, it is not associated with worsening of the cardiorespiratory movements or embarrassment, but rather it improves it because the baby is going down. Right? So the clinical symptom which is relieved by lightening basically is dyspnea, the shortness of breath that the pregnant lady has. That is relieved by lightening. Is this clear with everyone? So this is other topic that the question has been asked on. I've included all the topics that have been asked in the UPSC CMS exam from 2019 to 2025. Okay, all of those have been included. Whatever questions on labor, abnormal labor and complications has been asked. Going to initiation and characteristics of labor, true labor pains versus false labor pains. True labor pains are rhythmic, right? And they increase in frequency, intensity, and duration, right? Progressively, they increase in frequency and also in intensity and duration, while false labor pains are irregular. They do not increase in intensity. True labor pain is associated with cervical effacement, the shortening and the dilatation. Here, the cervical change is not there. If it's a true labor pain, the cervix changes will also take place. Then there's going to be the membrane wala formation of the bag of 4 waters that's going to be there. Here there's no such bag or the membrane remains intact. And remember the pain. Here it starts in the back and radiates to the front of the abdomen, while the false labor pain is what is confined to the lower abdomen and groin. Right? So remember, this is suggestive of false labor pain, not true labor pain, a previously asked question. If the pain is in the lower abdomen and groin, it's a false labor pain. Right? True labor pain, back mein start hoke, fir aage it radiates to the front of the abdomen. Now, even there has been a question on the physiology of labor initiation. What all factors help in starting the labor? First is uterus distending. Because of that, what happens? The myometrium gets stretched, right? So that is stimulating the contractions. The fetal hypothalamus pituitary axis mein kya hota hai? There is increased CRH. I'm sorry, just a minute. There is increased CRH and ACTH that comes from the fetus, which stimulates cortisol, right? And because of that, what happens? The estrogen synthesis is promoted over the progesterone synthesis. Okay. So remember that what happens when the estrogen preferably is coming just before the labor, helping in starting the labor. Because of the estrogen, what happens is the myometrium mein the oxytocin receptors get increased. So that is how the hormonal shift from progesterone to estrogen is helping. Remember, labor is initiated by progesterone withdrawal, not an increase in progesterone. This is also a question asked. It is not the increase in progesterone, rather the progesterone withdrawal that is leading to labor. Estrogen has a role in labor initiation. Okay. Remember, the hormone which is maintaining the pregnancy throughout, that is basically progesterone, the uterine tranquilizer. right, which is maintaining the pregnancy, not inducing the contraction. While estrogen, when it comes, it will increase the oxytocin receptors and help in the uterus contraction. Okay? So remember, increased CRH and ACTH also have a role because it increases cortisol, increases estrogen, and that in turn increases the oxytocin receptors. Next one, stages of labor: first, second, third stage, and then the fourth stage. What is the first stage of labor? Till the cervical dilatation. Full cervix dilatation is still 10 centimeters. So till cervix dilatation it is. So from onset of the true labor pain to cervix dilatation full, it is first. Second stage is the stage of expulsion, the delivery, the baby coming out. And third stage, after the baby, what remains is the placenta. So third is the placental expulsion and the membranes expulsion. Fourth stage is basically observing the patient for 1 to 2 hours post placental delivery to monitor for PPH. That is post placental delivery observation. Is this clear with everyone? And that is why you have something called as active management of third stage of labor. Why do you want to manage the third stage actively? Basically to prevent PPH. Okay, to prevent PPH. Is this clear with everyone? Yes? Just a minute. Right? So first stage is still dilatation, second is the baby coming out, and third is the placenta coming out, and fourth is the observation phase. Okay? Right? This has been removed now, but remember your questions can still be asked on the historical term, so that is what you should know here. Coming to mechanism of labor and pelvic anatomy, the question on what is the engaging transverse diameter of the fetus. So read the question carefully. It has asked the transverse diameter, not this anteroposterior diameter. Transverse diameter engaging is the biparietal diameter, and anteroposterior, the most common, which comes in a well flexed vertex presentation, is suboccipitobregmatic. Sub, remember sub. सब डिलीवरीज में जो नॉर्मल डिलीवरीज हैं with well flexed vertex, it is sub diameter, that is sub occipitobregmatic. It is 9.5 centimeter. Which one is the longest diameter of the fetal head that you have? And in which presentation does it come? Remember, like the longest car, BMW, you have BMV. In bro presentation, you have mento vertical. Okay, that is the longest. Right, it is bro presentation, mento vertical, 14 centimeters. That is the longest diameter. Okay? Coming to the sequence of the cardinal movements, right? Cardinal movements of the fetal head occurring. What is the sequence? Again, the question on that. So remember it as, you must have heard that song, Ude Dil Befikre. So remember it like Befikre. You write it like this. You start with E, and this is the sequence, E Fikre. That is engagement, flexion, internal rotation, crowning, restitution, and external rotation. Remember, E coming twice. The first E is definitely going to be engagement that occurs. First is the engagement, last is the external rotation, right? बाहर आके जो rotation हो रहा है ऐसे याद रखना, that is external rotation. पहले होता है internal, फिर होता है external. Okay? So what is restitution? Restitution is the external rotation of head by 45 degrees, which occurs after delivery, basically for realigning the head with the shoulder. That movement is called as restitution. Restitution is like repositioning the head in line with the shoulder. Okay? Right? Now, plane of least pelvic dimension, that's basically the obstetric outlet. At what level do you have this? The plane of the least pelvic dimension, सबसे कम diameter of the pelvis, is where you have those projections. That is the ischial spine. Ischial spine is what station? That is 0 station. Okay, so that is the obstetric outlet, the least dimension wala plane. Now, what is the significance of this? Because this is the narrowest plane. That is where the deep transverse arrest occurs, and this is where also the internal rotation is completed. Right? सबसे कम है तो arrest सबसे ज़्यादा यहीं पे होता है, and internal rotation यहाँ पे complete होता है. Remember, the question which had this option was incorrect. The backward curve of the pelvic axis, it does not start at the plane of least pelvic dimension, but at the plane of the greatest dimension. The backward curve of the pelvis does not happen at the least pelvic dimension. Least pelvic dimension is zero station, right? Deep transverse arrest, internal rotation, but not the backward curve of the pelvis. Backward curve is at the greatest dimension. Okay, is this clear with everyone? Right? Going to next one, monitoring the progress, पार्टोग्राफ पुराना और जो नया वाला WHO लेबर गाइड आया है. What is the difference between the two? The WHO labor care guide, which is the new one, and the modified WHO partograph. When do you call it start of active phase? Remember the first stage of labor, that is full dilatation of cervix. It has a latent phase and an active phase. Active phase is defined according to the new guidelines. It starts at 5 centimeters. Previously, it was defined at 4 centimeters. And that is why till the cervix does not reach 5 centimeters, it is recommended according to the new guidelines that no intervention should be done. Right? No intervention for any delay should be done till the cervix is reaching 5 centimeters. Right? No oxytocin, no other intervention. Second stage of monitoring was not plotted in the previous one. Now it is said that the second stage should also be plotted. Okay, the second stage should also be plotted on the graph. Previously, there were these alert lines, and then you had 4 hours to the right of alert line, the action line in the partograph. Now there are no alert or action lines in the labor care guide. Traditionally, for the progress, it was said that 1 centimeter per hour se hona chahiye progress, but now it is 0.5 centimeter per hour because 1 centimeter per hour is said to be like too fast for some primaries. So now it is 0.5 centimeter per hour. The duration limit, it is not defined on the graph, but remember that here the duration limit for primaries, it is considered as 12 hours. For multi, it is considered as 8 hours for active first stage of labor. So primaries के लिए 12 hours और multi के लिए 8 hours. ठीक है? Is this clear with everyone? Yes. So the cardinal movements that I have mentioned here is based on the question that has been asked in your UPSC CMS exam previously, right? So those were asked in the question, so I've tried to include that. So remember, in the WHO labor care guide, the active phase starts from 5 centimeters, not 4 centimeters. There are no alert and action lines. Even the second stage monitoring is plotted, right? And it is the progress is, the limit is now taken as 0.5 centimeter per hour. And the limit for the active first stage in primaries is 12 hours, in multi is 8 hours. Now, the new monitoring parameters also included are the supportive care section is also there. So in the labor care guide, there is a section for supportive care for a better childbirth experience, which includes documenting that who is the companion, right? The presence of a chosen labor companion, oral fluids, how is the intake of fluids or food. Also, what has been used for pain relief, epidural, yeah, any other non-pharmacological methods as well. And the documentation of the posture, the position as well. Right, supine hai, left lateral hai, kaun si position hai, that is what is also documented. So remember, these are also the new parameters in the supportive care that has been included. Remember that routine pubic shaving enema is not recommended according to the labor care guide. Right, this is not recommended according to the labor care guide. Oxytocin before 5 centimeters also is not recommended. ठीक है? So the WHO 2018 intrapartum care guidelines, जिसके बेसिस पे labor care guide आया है. Active phase, again a quick review, starts at 5 centimeters. Dilatation should be more than 0.5 centimeter per hour, not the traditional 1 centimeter per hour. And the active phase should not be more than 12 hours in primary and 10 hours in multi. Not 8, but 10 hours in multi. Okay, clear with everyone? 12 and 10. What all do you monitor, right? Do you denote on the partograph? Remember, in the fetal condition, you have FHR, molding, and also the color of the liquor, right? Is it clear, meconium stained, or blood? So remember, M stands for meconium. Then you have the labor progress also, which is documented, the dilatation, the descent, and the contractions. In contractions, you document the frequency and the duration per 10 minutes. Maternal condition में pulse, blood pressure, even urine analysis is there. What is not there? The respiratory rate is not there. This has been asked in the exam. So maternal respiratory rate is not a standard component of the classic partograph, but there is pulse, heart rate, blood pressure, and urine analysis also is there, but respiratory rate is not there. Okay? Is this clear with everyone? Remember, so when there is like a protracted or prolonged latent phase, no intervention is recommended. It is just therapeutic rest which is recommended. Only after 5 centimeters of dilatation, intervention will be recommended if there is a protracted phase which is happening. Third stage, placental management, basically the stage of placental delivery. So what are the signs of placental separation? Previously asked question, what signs tell you that the placenta is separating? The uterus becomes firm, globular, and remember the fundal height. Does it come down or does it increase? What happens with the placental separation? So when the placenta comes out, imagine like seesaw जैसा movement है, placenta नीचे आया तो uterus का fundus ऊपर जाता है, it rises above the umbilicus, it does not go down. And what happens to the cord? The cord also there is lengthening because now the placenta is coming out. So the cord attached to it, there is apparent lengthening of the cord which is there and a sudden gush of blood which comes in. Okay? So remember the fundal height rises and there is lengthening, not shortening of the cord. And the uterus becomes more firm, right? It becomes more firm. So what is the Brand-Andrews sign? Brand-Andrews sign here in placental separation. So the Brand-Andrews sign basically involves pushing the uterus upward. If the cord does not retract, right? So you are pushing the uterus upward. If the cord is not going up, that means it is separated, the placenta is separated. That is the Brand-Andrews sign for testing whether there is placental separation or not. Recent 2025 last year exam question, mechanisms of expulsion of the placenta. So two methods, right? Two ways that the placenta can come out. The Schulz and the Matthews-Duncan method. This was asked in last year. So what is the Schulz method and the Matthews-Duncan method? So if this is the placenta, if the placenta is separating from the center, that is the Schulz method. If it is coming from the sides marginal, that is Matthew-Duncan. So remember it as MA. The marginal separation is the Matthews-Duncan and the central separation Schulz, S and C going together phonetically. So the central separation which happens in majority is the Schulz separation. So what happens with the central separation? The fetus side is what is presented first and the bleeding is less. That is called as the shiny side. So again remember S for S, Schulz में shiny side, fetal side आता है. Matthew-Duncan is marginal separation. So maternal surface comes first, MA again in Matthews-Duncan marginal maternal surface and there is continuous visible bleeding. So remember the two ways of placental separation, the Schulz and the Matthews-Duncan. Marginal maternal is going to be Matthew-Duncan method. Active management of third stage of labor. Remember what is given is oxytocin 10 units IM within 1 minute of delivery. Right, so to maintain that uterus ka tone, because atonic PPH is very, very common. So oxytocin 10 units IM, right, within 1 minute of delivery. Then there is controlled cord traction and uterine massage. Some resources say uterine massage regularly करना है, some बोलते हैं नहीं करना है, right? Then the cord clamping is delayed, not immediate cord clamping. Delayed मतलब कितना delayed? 1 to 3 minutes के बाद, so that there's more blood going into the baby and the iron stores are better. Remember, in the twin pregnancy ke delivery mein, when do you give oxytocin? Do you give it after the first baby has come out? Yes or no? No. Remember, oxytocin is not given at the birth of first twin. Why? Because if you give oxytocin at birth of first twin, तो वो uterus contract होगा, there will be no space for the second baby to come out. Right? So it is only after the second twin to prevent the trapping. right? You do not give it after first twin itself. Is this clear with everyone? What are the indications for early cord clamping? Now it is said the most important is asphyxia. Basically, when the newborn needs resuscitation, that is the cause of early cord clamping. Previously, the causes also mentioned are RH incompatibility to prevent the sensitization, infants of diabetic mothers to prevent the polycythemia, right? Even these have been mentioned previously. So RH, diabetes, and most important is asphyxia. If the baby needs resuscitation, then definitely you would go for immediate clamping. Okay? Done with this? Give me a quick thumbs up if this is clear with everyone. Yes. Again, a reminder, after this session, please give the test because it is very, very important to assess yourself. Right, once you watch this, right, very important, this applies for any exam. You watch a video, you assess yourself with the questions. That's the best thing that helps you in the recall. Okay, going to next one, the obstetric maneuvers and instrumentation. These maneuvers have been asked, so I've included it here. What is the Ritgen's maneuver? We have discussed the tricks for this in the short course also. Ritgen is the general maneuver, the regular maneuver that is used in a normal vaginal delivery, right? So basically to prevent for the fetus head, the fetus to come out very fast, because अगर बहुत fast हुआ तो perineal tear हो सकता है mother में. So the controlled delivery of the head, basically to prevent perineal tear in normal vaginal delivery. So that is Ritgen's maneuver. Macro is used in show. What is show? The shoulder dystocia. So remember, McRoberts is the first maneuver used in shoulder dystocia, where the mother flexes and abducts the thigh, abducts, flexes and abducts the hip. So that is McRoberts maneuver. What are the other maneuvers used in shoulder dystocia? Remember, Rubens, wood corkscrew, Gaskin and Zavanelli. Zavanelli is the last maneuver. You tell the baby Zava, Zava, Andar Zava. So it's like sending the baby back into the abdomen and then delivering it by LSCS. So that is Zavanelli maneuver. Okay. So Rubens maneuver, wood corkscrew, Gaskin, Zavanelli, all this is for shoulder dystocia. Lovesets. What is Lovesets maneuver for in breech delivery? You show the love with both the arms, right? Love, hug with the arms. So this is for delivery of the extended arms in breech delivery, not in shoulder dystocia. And Pinard's, P for P, that is for popliteal fossa. Basically, remember the legs. Okay, for extended legs in frank breech. That is what the Pinard's maneuver is for. Right? Coming to instrumental delivery, that is forceps and vacuum, the ventouse. Forceps ke liye, what are the prerequisites? The cervix must be fully dilated. The membranes must be ruptured and not intact. Previously asked question. Because you want the forceps to hold the baby's head directly, not the membrane. So the membrane should be ruptured and the bladder should be empty, so that putting the instrument is easy. There's space for it, right? And for ventouse or vacuum, remember this is instrumental delivery is recommended when there is second stage delay, or there is the FHR is getting non-reassuring, and ventouse vacuum is contraindicated, very, very important, in a preterm, premature, less than 34 weeks. Why? Because वहाँ पे intracranial hemorrhage risk ज़्यादा है. And it is also contraindicated in non-vertex presentation, because there's no firm skull-like thing to, to give that vacuum ka pressure. So remember, it's important that it should be more than 34 weeks and the vertex presentation. If not, then remember that the vacuum ventouse is contraindicated. Very, very important. Premature में नहीं करते हैं और non-vertex में भी नहीं करते हैं. तो breech हो गया, face हो गया, वहाँ पे हम नहीं करेंगे. Okay. Complications and abnormal labor like shoulder dystocia. What is the clinical sign that you see in shoulder dystocia? Remember, there is turtle sign. What is the turtle sign? Like you have a turtle So what happens in shoulder dystocia? The head has come out, but now the shoulder is not able to come out. So because of that, what happens? There's a pull on the head which has come out. So the head goes inside, like you have the turtle coming out from the shell and going into the shell. So remember that the turtle sign is suggestive of shoulder dystocia. That basically is the head retracting against the perineum. Remember, can you predict shoulder dystocia? When the patient is in labor, क्या हम बोल सकते हैं कि this patient will go into shoulder dystocia? No, remember it is unpredictable. Even this has been asked. ठीक है, this is unpredictable. Risk factor, is anencephaly a risk factor for shoulder dystocia? Yes, because the small head in anencephaly, it does not dilate the canal completely, and that is why getting the shoulders out becomes difficult. So remember that yes, anencephaly is the risk because of the small head not able to dilate the canal. Coming to uterine rupture, the scar rupture and the complete rupture. So scar, किसका scar है? Previous LSCS का. So there's going to be history of previous C-section. The rupture will lead to pain, scar tenderness, and remember it can present with hematuria as well, and the fetus will be affected, the FHR will be abnormal. While when there is complete uterine rupture, like the fetus is coming out, and that is why the fetal parts are felt very well, right? So remember that easily palpable fetal parts under the abdominal skin tells you that the fetus is now in close contact with the abdomen. That means out of the uterus, so there is uterine rupture. Because of that, the mother will go into hypotension and even the FHR will be absent. Okay, so this is suggestive of rupture. Okay. Coming to cord prolapse, मतलब cord आ गया, right, adjacent to the presenting part or even beneath the presenting part. When does that happen? Malpresentation, very, very important. There is highest risk in transverse lie. So when it is transverse lie, easily the cord can come out because here there is nothing down to prevent the cord from coming down. So transverse lie has the maximum risk of cord prolapse, prematurity, contracted pelvis, right? All these are the risk factors for cord prolapse. Okay? So what is the management? Knee chest position is given. You lift the presenting part. Do not manipulate the cord itself because that can lead to vasospasm and then affect the blood supply to the fetus. So you do not have to manipulate the cord, but the presenting part which is there, you have to lift it up so that it is not compressing on the cord. So basically, we are aiming at preventing the cord compression. So for that, you lift the presenting part, not the cord. Immediate cesarean section. Right? Will you make the bladder full or will you empty the bladder? Bladder should be filled, not emptied, because a full bladder again will elevate the fetal head, so decreasing the compression on the cord. So bladder filling is done, not emptying. Previously asked question. Okay, that's a previously asked question. Do not manipulate the cord itself. Okay, give knee chest position. Again, not allowing the fetal head to compress the cord. Elevates the presenting part. Fill the bladder, not empty the bladder. Okay? And transverse lie is a very, very important risk factor. Okay? And coming to constriction ring. Constriction ring versus the Bandel's ring. What is the difference in between the two? The constriction ring is the localized spasm which can occur at any level. It is not at the junction of upper segment and lower segment. कोई भी level पे हो सकता है. And remember, the uterus does not rupture in the constriction ring. And you cannot even feel it. Right? So remember, it is not felt per abdomen. The constriction ring is a localized spasm occurring. You cannot feel it per abdomen. Right? On the other hand, Bandel's ring, which is the retraction ring. Remember, it as Bandel's is band. What is band? The labor is band. That means it is obstructed labor. So Bandel's ring is something that you see in obstructed labor, right? And that is what can be palpated abdominally, and it is suggestive of obstructed labor. So constriction ring can occur at any level, not only at junction of upper and lower segment. Right? And remember, it does not lead to rupture of the uterus and you cannot palpate it abdominally. Bandel string is something that you can feel abdominally and it is suggestive of obstructed labor. Okay, that is suggestive of obstructed labor. So, yeah, this was the quick review of the topic of labor. Try to include the most important points that have been asked, and repeatedly you would see questions on this in your UPSC CMS exam. I have not gone into the details of the topic, right? Because the exam is very near. If you do that, doing a lot of topics would become difficult. So at least do something of all the important topics that have been asked in the previous years, right? Because at least you do not make a mistake in the PYQs. That should be the most important priority for any exam. Okay, is this clear for everyone? Test is available, Assault Ashik. On the Medsynapse app by Dr. Nikita, the test is available. I'll try to pin the link of the test in the comments after the session. So directly you can go to that link and you can give the test. Okay, so there is 35 questions test. इतना सा topic जो हमने discuss किया है quickly, right? You have 35 questions test on this topic of labor, whatever we have discussed. Try to assess yourself with that test. Very, very important. Okay? Yes. The test is available for the UPSC CMS subscribers. The UPSC CMS course subscribers. Okay. So guys, I'll see you again in app Medsynapse app at 7:30 p.m. for the next very important topic where you definitely have questions, and that is the topic of contraception. In that topic, I've tried to include extra points also, like, you know, the topic of missed pills or IUD strings not visible. Right, though they have not been asked previously in UPSC CMS, but definitely you have chances of being asked in the upcoming year, right? Hitesh, definitely, let's connect. Please drop me a DM on Telegram. I would be happy to connect with you, and heartiest congratulations for clearing the FMG exam. Super proud of you. Regarding postponement, again, remember, as much as you are unaware of what is going to happen, so is with me, right? So let's not get into it. Let's focus on, you know, the exam on 2nd August itself, because abhi to wahi hai. Okay, I'll share the annotated PDF also in app. So you'll be able to see this video in app also later on with the blank PDF, the annotated PDF, and the test also attached to it. And 7:30 p.m. we'll connect in app for the topic of contraception. After that, day after tomorrow, we shall have the discussion of the topic of immunization and vaccines. Tomorrow, we will have mini GT discussion for NEETPG. So all the short subscribers, right, you shall have a mini GT of 36 questions that will be there and discussed tomorrow. Okay. Thank you so much, everyone. Goodbye. Take care. Keep studying, keep revising, keep med synapsing, and keep winning. Thank you.